Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Osteoporosis, which is characterised by low bone density and bone tissue deterioration, affects 2/3 of Australians over the age of 50. Healthy Bones Australia has been contracted by the Department of Health and Aged Care to update the 2017 guidelines for osteoporosis management. A summary of this update has now been published in the Medical Journal of Australia. Professor Peter Wong is a rheumatologist and head of rheumatology at Westmead Hospital and the honorary medical director of Healthy Bones Australia. He is one of the co-authors of the guidelines and joins me now. So tell us about the new guidelines on osteoporosis management.
Yes, well, look, Sally, thanks for asking me to chat about this because it's a really important issue. So the last guidelines that Healthy Bones Australia and the RACGP did was 2017, and the field has moved a lot in the intervening 7 years. So these new guidelines came out about 12 months ago, actually, and they're written for GPs. There are 7 people on the writing committee, which I had the privilege of chairing, and 3 of those are GPs who are in active clinical practice. So we were very cognizant of things that GPs need to know. And really, it's a large document, and I don't expect people to sit and read through every single word and comma and paragraph as I had to. But I think the key things are from the 2017 guidelines, we got a lot of feedback from GPs saying, look, we need some guide of absolute risk. And so for that reason, we have suggested people use FRAX, F-R-A-X, and there's a website, fraxplus.org, which is an absolute risk fracture calculator. And we're hoping that when you go to the website, play around with it, type in some numbers of your patients, it'll give you an absolute measure or a measure of absolute fracture risk that we hope will get people thinking about how to improve bone health. So FRAX is what we have suggested. The Garvin risk fracture calculator is still very useful for those who fall, because FRAX at the moment does not have falls as an input parameter. And obviously, if you don't fall, you're unlikely to break. But FRAX is probably the one we'd suggest unless you're at high risk of falling, because it's validated in lots of populations around the world, and also is spat out by a lot of the DEXA reports that people get. It's kind of on the usually the summary report at the end of the DEXA printout that you get. So we've suggested use of an absolute risk fracture calculator. We've also, there's this lovely, well, at least I think it's lovely, flow chart, which is, I think in table 2 or figure 2 of the paper that we've just published in MJA. And it's a very helpful flow chart that we hope people will kind of print out, if people still do that, and stick it to their walls and things. That talks about imminence of very high fracture risk. And so this is an evolving concept, and there's no internationally accepted definition of very high fracture risk around the world, but we've put together a few thoughts about it. And so someone who's at very high fracture risk is worth identifying, and we put some parameters there, including, T-score worse than -3, or recent fracture, or recent couple of fractures, and also a FRAX result that's more than 30% at 10 years. And so this group of very high fracture risk patients are worth thinking about and identifying, because we now have access to bone anabolic agents. And so bone anabolic agents is the other new thing that we've spent some time in the guidelines discussing. So up to now, most of our drugs have been what we call anti-resorptives. So this is the bisphosphonates that we've been using for 40 years, things like alendronate and risedronate. So anti-resorptives preserve what you've got, which, don't get me wrong, is a good thing. So they preserve the bone density that you have, with maybe a little bit of an increment. But bone anabolic agents actually build new bone. And so they really are amazing. We've had a bone anabolic agent for many years, and that's called teriparatide. It's been around 20 odd years in Australia. It does have a daily subcut injection, which can be problematic, particularly for my arthritic patients who have poor hand function. But there is a newish drug called romosozumab or Evenity, which is a bone anabolic agent, and it's the most potent bone anabolic agent we've ever had because it does two things. One is it is a bone anabolic agent, so it builds new bone, which is great. But also it preserves what you've got. So it's got an anti-resorptive effect. It's the only drug we have that does the two actions. And so we were really keen to talk about that in our guidelines and say that, look, this drug is now available on the PBS. So please have a think about it. And romosozumab is interesting because it's been around in Australia on the PBS probably for about 4 years now, but it's only been for those who fractured despite anti-resorptive therapy. We know that in data all around the world that we probably should be using it up front or early on to build new bone. And then so you build and then you preserve with an anti-resorptive. And as of November last year, so 2024, the PBS came through and said, look, we can now use it first line in people that have a T-score worse than -2.5 and who've had a hip fracture within the last 24 months or have had two previous fractures in the last 24 months. So again, it's on the PBS website. So you can now use romosozumab first line in those groups of patients where you can build new bone, which what you should be doing, and then you preserve what you've got with an anti-resorptive. So I think the new guidelines really the use of fracs, this identification of very very high fracture risk patients, and the reason for that is that because now we can use a bone anabolic upfront, which we've not been able to do. So that's probably the key take-home messages I think from the guidelines.
Are there any other ways clinicians can identify a high-risk patient?
Yeah, so it is tricky because there is no internationally accepted guide or definition. But in our guidelines, we have identified people, we've tried to put together what's in the worldwide literature. So if someone has a T score worse than -3.0 on DEXA, so that's really thin bones, if they've had a recent fracture within 2 years, because we know that if you had a low trauma fracture, within 2 years is that high risk window when you're likely to break another bone. So that puts you in the very high risk group. If you've had two or more previous fragility fractures, so fragility fracture is what we also know as a low trauma or minimal trauma fracture. So it's a fracture sustained following a fall from a standing height. So if you've had two or more of those, that puts you in the very high risk category. If you've got medication like, you're on corticosteroid that some rheumatologist has put you on for your rheumatoid arthritis, if you've got a low BMI, or if you're at high risk of foiling, or if you have a FRAX major osteoporotic risk of fracture of more than 30%, or a hip fracture risk of more than 4.5%, sort of any combination of those factors puts you into a very high risk. And if you are at that very high risk, then probably we would suggest that now that romosozumab is available as first-line therapy, probably GPs should be thinking about involving a bone specialist. Your friendly bone specialist, whether that's a endocrinologist, rehab physician, rheumatologist, geriatrician, whatever, someone who's into bone, who can probably initiate Romo up front. And obviously that's the very high risk group, but also just anyone who's over 50, who's had a fracture, one should be thinking about, do I need to address bone health? Because the recommendations we've seen are written for postmenopausal women and men aged 50 years and over.
What types of supplementations are recommended?
Yeah, so we spent a lot of time agonizing over sort of calcium and vitamin D supplementation. It's been the eternal bugbear. And look, the bottom line with that is that really calcium and vitamin D supplementation, there's been a lot of ink spilled about it over the years. We looked at lots and lots of papers. But really, calcium and vitamin D supplementation is for those who need it. And so it's for those who need it. So people basically who are well community dwelling, and mobile people probably are not going to benefit from calcium and vitamin D supplementation. But if someone is institutionalized, elderly, at high falls risk, and frail, then they're the ones really that we should be thinking about calcium and vitamin D supplementation in. And again, we've written quite a lot about that. We were doing this, there was a study that came out that caused quite a lot of angst. And that was the VITAL study. It got into the New England, so it was very high impact journal. And that showed that people who are vitamin D replete, when you then give more vitamin D to them, it doesn't really lower fracture risk. And so that caused a lot of angst. But it's important to remember that study was done in people who were predominantly vitamin D replete. So the take home message is that if you're healthy, non institutionalized, and well, probably calcium, vitamin D, and protein supplementation is not routine. If you are frail, institutionalized, and older, then you really want that target calcium to be 1,300 milligrams per day, ideally from dietary sources. But if that's not possible, then a calcium supplement is reasonable. You should be aiming in that frail, institutionalized older group for a serum 25-hydroxyvitamin D level of more than 50 nanomoles per liter, and also a protein target of 1 to 1.2 grams per kilogram body weight per day. But that's in frail, institutionalized older people. If you're well, healthy, non-institutionalized, active, you probably don't need routine dietary supplementation for your bones.
Right. And when you say that ideally it's from dietary sources, these days, what would you recommend to be the best?
Yeah, it's essentially dairy. So again, for your listeners, so Healthy Bones Australia does this really good spiel on it with lots of stuff you can give patients. If you go to healthybonesaustralia.org.au, there's a drop-down menu where there's lots of information about calcium and vitamin D, but essentially it's one serve of a cheese, a tub of yogurt, and a glass of low-fat milk a day will kind of get you in that ballpark. And look, that's hard for a lot of people, particularly if you're, from an Asian background or a non-Caucasian background. We don't drink that much milk or have that much dairy in our diet. So then you may well need a calcium supplement. But again, healthybones, Australia.org.au's got lots of information on that.
Does that include a milky coffee like a latte?
No, that should be okay. I mean, you probably shouldn't be drinking 10 of those, lattes a day, but certainly, having a bit of milk in there is probably a good thing. But again, you're going to have a lot more calcium in your diet than just a skim latte a day. So, a tub of yogurt, a serve of cheese, and a glass of low-fat skim milk a day is probably a good thing for all of us to be doing.
Is there anything else in the guidelines that you would like to highlight?
If we could just perhaps reiterate to your listeners that basically anyone who's over 50 and had a fracture, please think about bone health issues. If there's one thing you had to read from the guidelines, probably that flow chart that we've spent a lot of time thinking about, which is figure 2 in the MJA article. Please have a bit of a read and a bit of a think about it, because we've tried to distill all that into that one flow chart, and which is pretty hard to do. We know that GPs are really busy people, got to be good at lots of things, whereas I just need to be good at one thing. We've tried to make things as simple as possible.
Lastly, as a rheumatologist, how did you develop such an interest in bone health?
Oh, so it was actually very early on when I was a registrar here at Westmead a long time ago. I did a research project looking at how many people following a low trauma or minimal trauma fracture, so a fall from a standing height, how many of those were actually treated for osteoporosis? And the answer was terrible. It was less than 20%. And it's been like that for donkey's yonks. So I thought, I'd like to try and do something about this. That kind of sparked my interest in bone and bone health. And I also think as a rheumatologist, we use prednisone. Prednisone is our favorite drug. We love it. We use it for all sorts of things. But unfortunately, one of the major issues with prednisone and corticosteroid is that it thins your bones and causes osteoporosis and fractures. So I think if I tell my children all the time. If you make the mess, you should clean it up. So I think it behoves rheumatologists, but also obviously anyone who's involved with patients to kind of think about osteoporosis and to address bone health in their patients, which is most of us, really.
Okay, great. Thank you to my special guest, Professor Peter Wong. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thank you so much for listening.